First of all, thank you for coming this morning. I really appreciate it. The one thing I want to do, though, is start with an orientation because, just to remind you, this is Monday morning, not Sunday morning, because I will be constantly talking about the book. And the book I'm talking about this morning is not the book most people talk about yesterday morning, but this book. The other thing to orient you, this is not an AA meeting, so I'm not talking about the big book, okay? I am talking, it is a big book, and it's a very complicated book, but it is the DSM-5, and the entire day we're going to be talking about that book. My quick background, I went to medical school at Loyola University in Chicago. I did my residency at the University of Chicago. I was medical director of Madden Mental Health Center, which is a state hospital in Chicago. At the time, which will show you how old I am, I was medical director at what was then called an intermediate term care unit at Northwestern University, which was approximately 3-month hospitalizations, which I know don't exist anymore, for eating disorders and personality disorders. So it was a very specialized unit that nobody pays for anymore. So, and then I was in private practice for 26 years. And then I found myself here, and that story I'll tell you over a cocktail later in the day. So, but I'm very glad to be here. I'm very glad to be at Life Transitions, and it's a very exciting time for us. So, I am going to show you the next slide, which is the most important slide of the entire day. So please pay, if you don't pay any attention to any other slide, pay attention to this one, which is I am only the messenger. Okay? I did not write the DSM. I did not have anything to do with it other than I am conveying information. And so just remember that, and I think I'm speaking for Elaine also. So these are the resources I used. They're obviously the DSM. There's a master course that the APA put on, several other courses and slide presentations. There are tons of articles out there on the specific subsections. So obviously you can do lots of research. Disclaimers, I do not know everything about the DSM-5, but I'll try and give you the most useful information I can. What I am aware of is the tentative implementation date right now is January of 2014, so it's only a few months away. The other major system of classification that's used is ICD, currently 9, soon to be ICD-10. So throughout this talk, I will be referring, I will be talking about DSM, but giving you cross-references to ICD 9 and 10 on the coding part. Okay, I'm assuming most people here are clinicians of one discipline or another. But you know, as clinicians, we have to be aware of the coding, and when we make diagnosis, the diagnosis has to match the codes, and the codes can be very complex. So just to let you know. Today is almost exclusively going to be focused on adults. In talking about the changes, there have been changes in the children's section and in the structure of the thing, but like I said, what I'll be predominantly talking about is adults. There is a lot of material to cover, and when we put this together, we narrowed down the focus. And even within that narrow focus, it is quite possible that what I've prepared we will not get all the way through. So I've also prepared in a way I can lop off sections just to make you aware of that. Questions are welcome. Answers may be harder to find if you ask a question. So, but please feel free to answer or ask questions. And I'm going to keep the pace really brisk for 2 reasons. One is to cover the material, but 2, I have gone through in my head 1,001 ways of how do you make this interesting, because the DSM is essentially a list of lists, and everything is a list. And the more deeper you go into it, the next list you find. And there's no way I can't tap dance through it, I can't tell a funny story. So I'm going to try and keep it brisk, and what I've tried to do is keep it very pertinent to what you guys are going to necessarily use every day, and give you the overall outline. So, as I said, I'm going to default to the main purpose of my talk is going to be the overall structure of DSM-5. Now, I did break out theoretically, if we get through my first part, the second part of my talk will be focused on neurocognitive disorders, on substance use disorders, and on personality disorders, because they are areas where there have been significant changes, and or for personality disorders, there has been almost no change from 4 to 5. But if you look in the section 3, and I'll talk about this, what's in section 5 is a dramatically different model of personality disorders. And that is undoubtedly where the future is going. So, though they made almost no change now, what's coming whenever DSM-6 or 5R or whatever they decide to call it is going to be very, very different. And it's very much more complex. So a brief history. The first edition was published in '52. It was meant to increase the reliability of diagnoses. Second edition was in 1968. Third edition in 1980, and it was only in 1980 that they introduced the multi-axial approach. And what it was trying to do is make diagnosis of mental health disorders consistent between the US and Europe predominantly used WHO. Now, if any of you read any of the international mental health literature, you'll see that nowadays, at least within most of the mental health disciplines, they refer to DSM when they're doing a lot of the international stuff. They don't generally refer to the ICD codes. They added social and cultural factors in 1980. That's where they came in with Axis 4 and 5. At that point, it was a mere 494 pages with 285 diagnoses. It was reprinted in '87 as a revised version, a little reorganized and renamed. Pages went up to 567, diagnoses went to 292. DSM-4, 94, it went up to 886 pages and 297 diagnoses. So then 4TR was published in 2000. There were really no significant changes. And here we are in 2013 after many, many years of work and controversy with the current product. Now, nobody knows how long DSM-5 is going to be around before there's a DSM-5R or 5T or whatever that. But essentially, when you talk to people, what they expect this version to be around in its basic format is probably for about 10 years. In terms of if you look at how long it takes for the research to be done, how long it takes for revisions, etc., that's probably what it is. So there's a net difference between 4 and 5 of 15 diagnoses. DSM-5, the project was started in 2000, and it was projected to be published between 2012 and 2014, and they did hit that. It was, as a matter of fact, right in the middle. It was published in 2013. Every single section had its own work group. Every single section, those work groups had subcommittees of a variety of areas within each of those things. So there were, and it was predominantly, the work groups consisted predominantly of academicians, people who are in academics, both MDs and PhDs. So it's a very research-based book at this point. It incorporates, interestingly enough, this is the first time this has been the case, cognitive neuroscience, brain imaging, epidemiology, and genetics. So every single section now talks about those areas. This is the future, right here. And from now on, everything will be going in that direction. And you will be hard-pressed to see a diagnosis come in that does not have some support in those areas. And all the diagnoses were field tested, meaning once the committees came up with their diagnoses, actual real live boots on the ground clinicians became part of testing the diagnoses for reliability, comprehension, usability, et cetera, et cetera. So it was field tested extensively. So what are the guiding principles? First one was clinical utility. In other words, how useful is this when you, the clinician, are sitting there with a patient? Research. One of the things you'll notice as you go through the DSM-5 is that the number of specifiers and subtypes and things you can add on to a diagnosis have multiplied tremendously. Because what it's trying to allow you to do as a clinician is, one, describe clearly what the patient has, and two, it's to use it for research, essentially, so that when the researchers go out there, let's say they do one of these studies where they're pulling in diagnoses from insurance records, which they do, blinded, but they do it. They want to try and make sure that that information is more consistent and reliable than it has been in the past. They wanted to maintain continuity with previous editions, so they didn't want to throw out the baby with the bathwater, so to speak. And they did not put any predetermined restraints between DSM-4 and DSM-5. In other words, they did not predetermine any set parameters. So it was a pretty open book as far as they were concerned. So what's a mental disorder? Because obviously this is really important when you're diagnosing somebody. And when I get to section 3, you'll see that they spent a great deal of time flushing this out, because as we all know, there's always been a great deal of controversy about where is that line between normal and abnormal. When do you diagnose somebody as having a mental disorder? So a mental disorder is a syndrome that's characterized by clinically significant disturbances in an individual's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. So what's the bottom line takeaway from this bullet point? It has to be clinically significant. So if it's not clinically significant, don't make the diagnosis. And it has to be clinically significant in a way that there is some practical dysfunction that's occurring that's impairing that person's life. So we get to the second bullet point. Mental disorders are associated with significant distress or disability in social, occupational, or other important functions. So in other words, once again, you're talking about there's a threshold here where you should not diagnose somebody unless you see that there is something going on that is disabling them. It doesn't mean they're totally non-functional, but that it is getting in the way of their life. There are a lot of odd people in this world. Odd people do not get diagnoses, okay? Most of us would have a diagnosis if odd people counted. Okay, let's be honest. So there has to be a level of dysfunction. Not mental disorders, an expected and culturally approved response to a common stressor or loss, such as the death of a loved one. I'll cover this in more detail, but for those of you who know anything about DSM-5, you know bereavement no longer exists in DSM-5. That's been excluded. And that is what it's referring to. Socially deviant behavior, for example, political, religious, or sexual, and conflicts that are predominantly between the individual and society, unless the deviance or conflict results from a dysfunction in the individual, as described above. Well, what are they saying here? They're saying if you have politically different views in China, you can't be put in jail as being mentally ill. That's the simplest example that I can give you. So just because you have a different view from society does not mean, the general society does not mean you have a mental disorder. Now, if I'm a paranoid schizophrenic and I think I'm Jesus, does that count? Yes, that counts. Okay, that's different than having a politically different view. Okay, so that's what that section is talking about. You have to incorporate age, gender, and culture-specific factors and sensitivities to these factors when making a diagnosis. The clearest example, certainly down here, that I could give you is we have a large Native American population. There are certain cultural beliefs that the Native American population has. Just because they have those cultural beliefs does not mean that they have a mental illness. It means they have a specific type of cultural belief that to someone else might seem odd, but that is not a mental illness. And diagnostic guidelines for understanding human behaviors are not to be considered legal definitions to be used by the law and law enforcement. Once again, this is a little more complicated and confusing, but what they're basically saying is, in a court of law, you cannot use a mental illness diagnosis as saying the person is guilty or not of that particular crime. It may come into play, but de facto, for example, if you are schizophrenic and you are paranoid schizophrenic and you kill somebody, just because you're paranoid schizophrenic does not mean you get to be innocent. Okay? And I can give lots of other examples of that. Someone can be paranoid schizophrenic, be psychotic, and still know what their actions are and what consequences they have of their actions. So that's what that is trying to sort of get to. It should have clinical utility. In other words, it should help you determine prognosis, treatment plans, and potential treatment outcomes for the patient. If you're giving a diagnosis to somebody that has absolutely no value to their treatment, to their life, to what services they can get, then you really have to ask yourself, why are you giving that diagnosis? What are you doing for that person? And the diagnosis is not equivalent to treatment. In other words, you can say somebody has a diagnosis, but they may not need treatment. I mean, somebody may have a mild depression, and it may not necessarily be so severe that it's really interfering. Now, you could suggest that they get maybe some CBT, but it may not truly be severe enough where they need treatment. The way they validated diagnoses to have them count is there were really three components. There were antecedent validators, meaning before you actually sort of looked at the person, are there genetic markers? Are there family traits? Are there temperaments that are common? Are there environmental exposure? So when you look at DSM-5, on the textual part of the disorders, you will see each of these things to the degree that it's pertinent for each of those disorders to be present. Then there's concurrent validators, similar neural substrates, biomarkers, emotional and cognitive processing, and symptom similarity. And then the last is predictive validators. In other words, if you give someone a certain diagnosis, within that, can you see a similar clinical course and treatment response? Now, this all sounds wonderful, doesn't it? Doesn't it make it sound like mental health, we're really cool and that we can do all this good stuff? It's a lie. Okay? The amount that we can do that nowadays is very limited, and very limited to really a few disorders, if we're absolutely honest with ourselves. But we have to remember that DSM-5 is meant to not only be what we can use today, but it is meant to be what we can use tomorrow, and where the research can be guided by. So this is where all of the big money is going in terms of research. And this is, I do believe, where we will be. Now, will that be 5 years, 10 years, 20 years? I'm betting more along the 10, 20, 30-year mark, given where things are. But this is the direction everything is going. And there are a couple of areas where there has been significant progress in this, and it's some of the areas that you see the most changes in. The substance use section, there's been a major revision because there's a lot more information about the biological piece to substance use. Neurocognitive, huge changes in the neurocognitive section because of some of the work that's being done in that area. The validators cross existing diagnostic boundaries, but they tend to congregate within it and within and across adjacent DSM-5 chapter groups. Well, what that means is when you read down the chapters, all of those genetic factors, biological factors, if I talk about schizophrenia, they tend to cluster in schizophrenia. But the next disorder chapter after schizophrenia is bipolar disorder. Now, if I drew a circle of schizophrenia factors, okay, it's big circle, bipolar disorder, another circle with a little overlap with schizophrenia. Interesting, in DSM-5, they separated, remember in 4 there were bipolar and, there was all affective disorders. No more. In 5, they separated out bipolar from depressive disorders. So now you have schizophrenia, bipolar, and depressive. Why is that? Because the genetics show that there is actually a distinction in that regard, and where the overlap occurs is much more with schizophrenia and bipolar than it is schizophrenia and depressive disorders. It's a pure entity. You can have both and you have complicating factors. So that's reflected in the absolute structure of DSM-5. Until etiological or pathophysiological mechanisms are identified to fully validate specific disorders, the most important standard for diagnostic criteria is clinical utility. So everything I've just said makes absolutely no difference if it doesn't apply when you make the diagnosis in terms of that person's day-to-day life and treatment. Genetic markers, neuroimaging, all of that other stuff, it's all wonderful. Don't we all wish we had one blood test to make the diagnosis? But it's still going to come down to your skill as a clinician to make the diagnosis. That's really what it still comes down to, and that's why DSM-5 is so important. But there is a cost advantage the more specific we can get when it comes down to some of these things. So the more specific we can get in diagnosis, the more specific we can get in treatment, the more pain and suffering we save for the patients, the more money we save for everybody. So it's the process of getting there that's going to be the challenge. There's always going to be fights about that. So, any other questions? Okay, so this is the overall outline of DSM. Section 1, DSM-5 Basics, is basically an introduction, how to, like a driver's guide, to use the manual, and a cautionary statement for forensic use. In other words, it basically says, be very, very careful how you use this in legal situations, and it explains why. Section 2 is the real meat of DSM-5. That is all of the chapters on the disorders with all the diagnostic criteria and codes. There will be, if you'll notice when you look in DSM-5, there will be the disorder, there'll be a code, which will be the DSM-5 code, parentheses, ICD-9 code, okay? And then, to make it even more fun, ICD-10 is coming out in the fall, and will be starting to be used. And so if you go to the back of the book, in the appendix and index, you will see lists of numbers and diagnoses that are ICD-9, ICD-10, numbers, diagnosis, same, different, numbers. Then you have separate lists if you want to go through separate lists, and all of it makes your mind spin. So what I would remind you is, unless you are a coder, unless you're someone who spends their life coding, most of that you will never use. Okay, so don't get freaked out by that. And that's a
physician using EHR. You are coding.
You are coding, yes, if you are. Section 3 is emerging measurements and models. This section has a whole bunch of different things in it. It's got cultural assessment, it's got case formulation, it's got the new DSM-5 personality model that was not chosen for this one, mainly because of, I think, a lot of political fighting on the Personality Disorders Committee, but what's coming to the future. So what's so different about DSM-5? Well, it's very different, actually. There are no more axes. The axes are totally gone. And the way you diagnose now is, so remember you did 1, 2, 3, 4, 5. Okay, forget it. So, except for the structure is the same. So what you would do is now just a list. Axis 1 are what are the major mental disorders. So major depression, schizophrenia, whatever. You would merely list what would have been on axis 1 and axis 2 in the order of clinical significance. Okay, so if you have multiple diagnoses on axis 1 and 2, you order them based on, for the current clinical situation, which is most significant. Okay, so that's the first thing. And if this clinical situation changes, let's say you've got somebody with major depression and PTSD. Okay, very common combo, right? Person presents initially with a major depressive episode, and they have PTSD, but you start off by you're treating them for their major depression. Hopefully their major depression gets better, but their PTSD is going to take a heck of a lot longer to get better. So a couple of things you will do. You may flip the order in subsequent diagnosis, when you submit in subsequence, because PTSD has become your primary focus of treatment, one. Two, your coding number for depression may change, because what was a severe depression may have become now a mild depression, and it's coded differently. Or the depression may have gone into remission, and the code number is different. So one of the things that DSM allows for is for you to very clearly show progress within the context of treatment, or, just as importantly, if someone is getting worse. So if somebody's been very steady and they have an episode of major depression and they've been in partial remission, you code differently when they come in the office and now they're in a severe major depression. So that's different. Axis 3 is the next thing you list. Axis 3 are the medical conditions that are pertinent to the psychiatric diagnoses. So, let's say somebody has high blood pressure, diabetes, chronic pain, okay, very common trio, right? See them a lot. But the only one that may be significant for, let's say, our major depression and our PTSD is their chronic pain. Because if somebody's in chronic pain, it's awfully hard to not have it affect your mood and all that goes with chronic pain. Hypertension, not so much so. Or their diabetes. Now it could, depending on the clinical situation, but you would not automatically list all three unless they were clinically significant. And then here's the fun group. This replaces Axis 4. Remember the V codes that we never used ever because insurance would never pay for them. And so they were really nice ideas and totally worthless on an everyday basis. Well, the V codes and Z and T codes are what's in ICD 9 and 10. And not only are there V, Z, and T codes, there's just little numbers too, by the way. So just to make it even more confusing. But the clinical utility now of the V codes is what I think has improved what used to be Axis 4. Because the V codes are really much more specific. So a lot of times, on Axis 4 you'd put poor financial resources, poor coping skills, pet salamander ran away, whatever. Well, now the V code is very specific about what is it right now for this person in their particular situation that is impacting their treatment. For example, we have many patients who we see with PTSD who have a history of child abuse, sexual abuse, physical abuse. There is a V code that you can use that is specific for an adult who has had child sexual abuse. Okay? And there are a whole bunch of there's adult abuse codes, there's financial resources codes, there are all sorts of V codes that are very real-world, boots-on-the-ground situation. Now, insurance is still not going to pay for it, okay? They will probably ask for them, but they're not going to pay. They're still going to reimburse on those first codes. But just like now we give them all 5, they want all 5. They're going to look for all of that. And it really does help you explain the clinical situation. Lastly, Axis 5, what used to be Axis 5, the GAF, no longer exists. It's gone. They totally eliminated it. Gone. However, they did not technically replace it with anything. They did present the HUDAS, the World Health Organization Disability Assessment Scale, which I will talk about, which will make your hair curl. And before you have a panic attack when we get to it, we'll go through it. This, supposedly, the HUDAS, is not required now, okay? Now, let's be honest. If you look at the HUDAS, and you look at how specific it is and the way it ranks disabilities, there is absolutely no way that I think that insurance companies and authorization companies are not going to require a HUDAS. It is far more useful than the GAF was. I hate to say it. It is far more complicated, it's far more thorough, but it's far more useful when you really come down to it. And even if we don't use it as much clinically, I can guarantee you when an insurance company calls you and is rating a disability claim, they're going to ask for a HUDAS. Because let's be honest, if you were an insurance company, wouldn't you want to know what the HUDAS was? The answer is probably yes, as much as we hate to admit it. So I think we're stuck with it, even though it's not required right now. I think once again, this was a gentle way of the DSM committee to basically say, here it comes, you know, just like they did with some of the other diagnoses that are now in 5. So, how else it's been changed? Do you remember in 4 how there was like a child and adolescent section, you know, and then there was sort of the dementia section, and it was not arranged in a way as per lifespan. It was arranged in a way for diagnostic category, okay, by age in many ways. Now that's not true. Each section is arranged in a manner that is lifespan based. So disorders that tend to occur earlier in life will be at the beginning of the section. Disorders that occur middle and later in life will be towards the end of the section. Okay? For example, in neurodevelopmental disorders, the old dementia, etc. section, it will start with mild and major neurocognitive disorders. Okay? Well, why does it start with that? Well, because younger people get mild neurocognitive disorders, okay? There's usually not a neurocognitive disorder per se that fits with a childhood illness or adolescent illness, so you don't really have a childhood diagnosis in that. If you look at the other sections, there will be childhood diagnoses early on in that section that would only apply to children, and they're usually divided between like 6 to 12 and then 12 to 18. So this has been totally restructured. The ordering of the chapters also have been restructured to generally reflect the lifespan. So that's kind of how they've conceptualized it. So as I said, disorders previously addressed in a single infancy, childhood, and adolescent chapter are now integrated throughout the manual. So you can't go and say, okay, I've got a 10-year-old, let me go look in the 10-year-old section of the book. It won't work that way anymore. Now it's just like an adult. You get an adult in the room, you have to go through your interview and that, and then you have to kind of narrow your thinking into what area of diagnoses are you thinking about. You know, is this kid a little psychotic? Are you going to look in the schizophrenic sort of section? Is this look more like a bipolar disorder, so I'm going to look there? So it's that sort of thing. So each of the disorder chapters, they start with the criteria. There are subtypes and specifiers. There are severity codes, and then there's an explanatory text. So list, lots of words, okay? So the lots of words part will talk about what the state-of-the-art current thinking is when we talk about genetic markers, epidemiology, neuroimaging. If there is information that is clinically credible and useful, then it will be in the explanatory text. So, and that obviously is going to change over the years as we develop more. So the explanatory text includes diagnostic and associated factors, prevalence, development and course, risk and prognosis, culture and gender-related factors, diagnostic markers. We're awfully thin in this, in almost the whole book. Functional consequences, differential diagnosis, and comorbidity. So it's a very, the explanatory sections are very thorough as you can get right now. And they're interesting if you read them in small segments. They're very dense to read. If you have insomnia, I suggest going to this section. And the other thing is, we all feel like, well, we have to read DSM-5 because, we just have to. This is what we do for a living. Realistically, I can tell you, you are not going to be able to sit down and read DSM-5 very long because it is just so dense when it comes to the criteria and the explanations that I really recommend putting aside like 10 minutes and then read like 10 minutes worth. Even reading an entire chapter at once, your brain is going to fuzz out by about a few disorders into it. So really, I think the way to approach this is read a very small amount at a time. And I think you'll get more out of it than trying to feel like you've got to sit down and read this like you're going to read a college textbook. Because it just is not, in my opinion, it's not readable. I mean, it in that sort of way. So what are the disorder chapters? Neurodevelopmental disorders. This is essentially many of what used to be the infancy, childhood, and adolescent disorders. Some of them have been renamed. Everybody probably knows about the controversy about the autism spectrum disorders, and there was a lot of controversy about that. The reality is the controversy in many ways was because people were afraid if you took away things like Asperger's, children would not be able to get the services they needed to help them in school, in housing, all the things that they got now. That seems to have been ironed out. So this section actually makes a lot more sense because some of those distinctions seemed rather artificial when you came right down to it. You gave somebody an Asperger's diagnosis, and the reality was there are Asperger's patients who are very high functioning and some who are very low functioning, but they all got the same diagnosis. And the changes that they made, I think, is much more realistic about how to use that. There are also a lot of communication disorders in here. The receptive language, expressive language, all those sort of things are in here. Schizophrenia spectrum and other psychotic disorders. Interestingly enough, do people remember the schizotypal personality disorder? Well, that got moved into here. And as most of us, I've only seen a true, what I would consider schizotypal personality a handful of times in my whole career. Because I think a lot of times they looked so ill that you really thought they were schizophrenic. My favorite story was, you remember when, I'm dating myself, but nonetheless, when the Challenger blew up, right? Okay. So I had a patient at that time, I was at the University of Chicago, and I had an astrophysics PhD candidate. Already you know you're dealing with somebody way off in the spectrum of intellect. And this person came in and said he had spent the weekend with his head in the oven, not on, but his head in the oven because he knew that this was going to happen. And this was his sort of punishment in his mind of doing this. And this was only this was the sanest of his thoughts. But he wasn't psychotic in the traditional sense of paranoid delusions, hallucinations, etc. He was a true schizotypal personality. So, but he awfully looked like this, very much so, but he didn't meet criteria. So this is one of those things where as we've gone along, it has made sense to take that and put it back here rather than in a personality disorder. Bipolar and related disorders, once again, separated out from depressive disorders. Anxiety disorders, interesting, look what's come out of anxiety disorders. OCD and related disorders are no longer considered a part of anxiety disorders. Why? Because the research has shown that the biochemistry and the neuronal networks for OCD are different and unique than what the general one is for anxiety disorders. Are they related? Yes, they're related, but are they distinct enough that you bring them out? Yeah, so once again, getting into that circle and where there's overlap, but yet there's distinction, That's this. Trauma and stress-related disorders, I'm going to let Elaine do that later on. Dissociative disorders, somatic symptom disorders, this is all of the disorders around physical symptoms, feeding and eating disorders, elimination disorders. This is a big section, and I'm not going to spend a lot of time on it. Sleep-wake disorders. This section has been really expanded, and the amount of science behind it has changed dramatically. So it's one of those areas that there's been a lot of changes within it based on science. Sexual dysfunctions, gender dysphoria, disruptive impulse control and conduct disorders. This is one of those interesting chapters where a lot of the childhood things have been moved into this chapter. So this is a great one to look at if you want to see how they've combined each chapter and made it more developmental, because there are a lot of behavioral disorders diagnosed in children. They have now been put in here, but then you move along and you get into the adult impulse control and conduct disorders as you go further down. So it's a great example of how they've reorganized it. Substance use and addictive disorders. Very interesting what's happened there. There is no longer substance abuse and substance dependence. No longer exists. Now there is only substance use disorder. Okay? And I'll get into that later. I think very smart, very well done. And they've divided that section into substance use disorders and non-substance use disorders. So, what's a non-substance use disorder? Well, right now there's only one, and that's gambling. And that's the only one that has met enough validity when it comes to research and scientific criteria to be under that section. But if we go to DSM, or if we go to the back in section 3, there are a couple of things that are under research. And I always look at DSM-3 as sort of the here it comes, we just don't have enough information yet. One of them in section 3 is internet gaming. That is coming, but we don't have enough data yet to actually put it in the non-substance use disorder. The other thing that's interestingly enough is caffeine addiction. But that would be in the substance use, obviously. But there, once again, if you want to see where the future is, go and see what they've put in 3. Because 3 means there's been a lot of research done, but not enough yet to be able to hammer that down as a diagnosis. Cognitive, I briefly mentioned that already, but I'll go over that later. Personality disorders, boring in 4, go to section 3, you'll be blown away with what the changes are. Okay, huge difference in section 3. Paraphilic disorders and other disorders. So,
can I ask a specific, just to kind of get a feel for this? Where does PANDA syndrome wind up?
Where? I'm sorry?
PANDA.
PANDA?
Autoimmune response to strep, you develop obsessive compulsive.
Yeah. That almost every one of these sections has a mental disorder due to medical conditions. So there is under OCD, there is a OCD due to medical conditions, and then what you should do is you diagnose so you would have that diagnosis, and then you would put what the medical condition is that is causing it. So, and that's true for all of them. So psychotic disorder due to, throw out a medical condition. Psychotic disorder due to alcohol intoxication. That would be under substance use. But all of the sections have something like that. Okay. Now, here are the new disorders. Social pragmatic communication disorder, this is a disorder of childhood. And I won't once again get into the specifics of these. Disruptive mood dysregulation disorder, but once again a disorder of childhood that's been further clarified. Premenstrual dysphoric disorder, well, we all know what that was, but what a surprise. It was in 4, now it's official in 5 as a real diagnosis. Once again, the level of research allowed it to be pulled out from the maybe section into the yes it is section. Hoarding disorder got separated out. We used to diagnose this under OCD. It's now a separate disorder. Once again, the research supports it as such. Excoriation skin picking disorder, same idea. We used to lump these two into OCD, and now they're separate disorder. Disinhibited social engagement disorder, split from reactive attachment disorder. Once again, childhood, splitting it out, more criteria. Binge eating disorder. Interestingly enough, once again, this was in the appendix, even though we on a common use basis didn't treat it like it was in the appendix, but now it is an official diagnosis. Central sleep apnea, split from breathing-related sleep disorders, sleep-related hypoventilation. Once again, remember when I said the sleep-wake disorders, how it's really been expanded, it's the science behind it? Well, you can see just by the number of new disorders with sleep titles how that section has changed. One quick thing, parasomnias. These were night terrors, sleepwalking. Now they're called rapid eye movement sleep behavior disorders. So, restless leg syndrome. Once again, we've had a lot of research. Used to be called dysomnia NOS. Nobody ever called it that, but caffeine withdrawal now exists as a separate diagnosis. Cannabis withdrawal. Remember, for those of us who have probably been around long enough to remember when, nobody ever withdraws from cannabis. That just doesn't happen. Wrong. But now we can officially diagnose as somebody being in cannabis withdrawal. And as most people know, this can last quite a while. This is not a quick process. Major neurocognitive disorder with Lewy body disease. This has now been acknowledged as a specific type of neurocognitive disorder. Okay, it used to be dementia due to other medical condition, but now it is a specific diagnosis that one can make. Mild neurocognitive disorder. Once again, it moved from the appendix back. Now it's in the full body. The other term for this, the old term that we were using for this was mild cognitive impairment, MCI. Now it's this. Once again, there's been a lot of changes made, and this is, once again, the changes are based on what the research has shown. Okay, that's what got something moved from one to the other. Sexual aversion disorder, polysubstance-related disorder. So what's the net difference from 4 to 5? Is we've gained 13 new diagnoses. From the one, if you look at the ones that have been added, the ones that have been taken away, the ones that have been combined, what did we end up with? 13 more. Which, when you really think about it, is we're basically in the same neighborhood. Because, once again, there's been lots of articles about, they're just expanding it, they're just adding more and more diagnoses, blah, blah, blah. The reality is that's not true. There's been more clarification, but overall number is approximately the same. What did they combine? Language disorder. Expressive language disorder and mixed receptive expressive disorder have now been combined into one. Once again, childhood, major revision. Autism spectrum disorder. You can see they took 4 diagnoses and it's now been put into one. Because there really is not clear justification for separating them into these disorders. They were more descriptive than they were empirically based. Specific learning disorder, they used to break it out into reading disorder, math disorder, disorder of written expression. When you get into the coding, however, you would diagnose specific learning disorder, and then if you look down into the coding, you have the ability to specify what disorder you're exactly taught, where the deficits are. And that's one of the differences in all of DSM. Delusional disorder, shared psychotic disorder, panic disorder, no more with or without agoraphobia. Why is that? Because many times you couldn't make the distinction. I mean, it's very rare to have somebody who has panic disorder who, because of their panic, doesn't find themselves limiting their activity. And so when did you decide if it was when they had agoraphobia or not? Did they have to stay in their house all the time? Some of the time? Only on Sundays? You know, it was just very unclear. So that's gone. Dissociative disorders, we used to make a distinction between fugue and amnesia, gone. Somatic symptom disorder, all these have now been just subsumed under one diagnosis. And insomnia disorder, once again, now it's based on primary insomnia or insomnia related to another medical disorder, but when you make this diagnosis, if it's related to another mental disorder, then you would specify it. But generally, this, insomnia, as we all know, sleep disturbance, is really a symptom of something else. So usually if it's related to another mental disorder, you wouldn't give this as a separate diagnosis. Because you would go through, let's say, a diagnosis of somebody and you'd say they have major depression. Insomnia is a symptom. So they don't really have an insomnia disorder, they have a major depression. So that's how you would use that one. Hypersomnolence, once again, notice all the changes within the sleep disorders section, huge. Sleepwalking, sleep terror, genitopelvic pain / penetration disorder, that's the old vaginismus and dyspareunia, has been combined into one, once again, because it was really hard to make a distinction that was of any clinical relevance. And this is a lot of showing you that for all of the disorders of alcohol use, all that was abuse and dependence now is one. Alcohol use, cannabis use, phencyclidine, hallucinogen, inhalant, opioid, sedative hypnotic, stimulant. Now, then you get into, there are other, so you've got use dependence that got combined. However, you still can get intoxication, okay, and you can get withdrawal for all of the disorders. And then substance/medication-induced disorders. So in other words, if you have a mood change based on the use of a substance or medication, this is the diagnosis. And this is under each of the sections. So psychotic symptoms, anxiety symptoms, mood symptoms based on a medication or a substance would be placed under a different diagnosis. Okay? Remember the old NOS? If you really didn't know what was going on, you called it NOS. Well, NOS went away, and what's taken its place is specified or unspecified. Now, what's the difference? This is a general description, so you have to look at each section. Other specified diagnosis is, for example, major depression. They meet most of the criteria for a major depression, but not all. So it looks like a major depression, it talks like a major depression, it feels like a major depression, but you can't come up with every single one of the criteria to make it. You would do other specified. And you would probably then, under other specified, make a modifier or explain what it is that is a problem, why you wouldn't make the full diagnosis. Okay? For example, let's say it doesn't meet the number of months it has to be around for, or number of weeks, but every other thing is met, then you might use other specified. Unspecified, you don't want to tell anybody why you're not making the diagnosis, is what it amounts to. Or, for example, somebody comes in the emergency room, you take the history, it's an emergency room setting, you know darn well this is a major depression, but you really don't have the amount of information that you need, you can't get collateral, but as sure as I'm standing here, you know it's so you would, on admission, do unspecified. Not because, and you would say unspecified, ER evaluation, insufficient information. But it would still mean you know darn well where you're going with this. So these are just some of the statistics on what was added, what was combined. But once again, overall the numbers stayed the same. VZT codes replace Axis 4. Usually you'll use V codes, and you use a V code or a Z code or a T code when you can't diagnose this as a mental disorder. Once again, victim of physical abuse. These codes explain either the need for treatment, a procedure beyond the diagnosis of a mental disorder, or another medical conditioning. For example, there's a V code for wandering. If anybody who deals with people who have neurocognitive problems know that that's a huge problem. But that's not a separate diagnosis. But it is frequently something that guides what you have to do in terms of treatment, your treatment plan. This explains the severity of what's going on. So now you have a V code that you can add to your list that says wandering. And that will tell the insurance companies, everybody, why this particular patient, for example, needs to be in a skilled nursing care facility. Because that's a big problem. So, and then it also can be factors that may affect the patient's prognosis or treatment. Extreme poverty. There's also V codes that talk about, I can't remember the exact phrasing, but it's like poor financial resources, inadequate access to health care. Things that we all know have a huge impact on treatment and should be listed. So the V codes really are quite useful. As I said, Z and T codes are from ICD 9 and 10. Some are actually numbers, like they're 995 point blah blah blah. Okay, that's a V code in hiding. Some exceptions, 278.00, that is overweight and obesity. You can list that as, it's a number, but it's a V code, okay? And in ICD 9, it's a T or Z code, but it actually starts with an E. So once again, VZT could also mean EGF, and it could also be just a number. Okay, but for the sake of simplicity, we're going to call them V codes. Okay? But when you go to the book, don't be surprised when you see lots of other letters and numbers. Okay? But basic idea. Relational problems. Once again, these are under V codes. Family upbringing, problems related to primary support group, abuse and neglect, physical, sexual, psychological. It's divided into children and adults. For adults, it's spousal and non-spousal. There's also one for perpetrators, if the person you're seeing is a perpetrator, as I put in this one. So once again, child victim by parent, by non-parent, adult victim by spouse partner, by non-spouse partner, and then if you're treating somebody who's a perpetrator. So that, once again, if you really think about it, if you do a good diagnosis and you list these, somebody should be able to look very quickly at what you've written, get a very good idea of the clinical situation. And that's what you really want. And that's, of course, what the insurance companies want. These are some of the other areas of phase of life problem, educational, occupational, housing and economic. Problems related to the criminal system. If somebody's not getting along with their probation officer, there's actually a V code for that. Which probably everyone's going to have a V code who has a probation officer. But encounters for counseling and medical advice. For example, if someone is smoking and that is something they're trying to get help for, you can list that as a V code. Or dieting. Once again, it just helps you flush out the clinical picture. And then other things. Problems with access to care, non-adherence. There's a big one right there. That one I'm sure everybody's going to have memorized very soon. Overweight or obesity, malingering, wandering associated with a mental disorder. Those of us who do a lot of work with Psych are going to have this one memorized within nanoseconds. Borderline intellectual functioning. Remember, this is the old mental retardation. Now it's a developmental disorder in DSM-5. This you would use if the person you suspect may have some sort of intellectual impairment, but you don't have enough data and you don't have enough history to really make that diagnosis, and you're not going to go through formal psychological testing to do an IQ. All right. Any questions before I go on to the next one?
I have one question. The borderline intellectual functioning, would that cover like FASD?
It depends on the situation. FASD, interestingly enough, has a diagnosis that they're exploring in the section 3. And that is a proposed diagnosis that they're doing more research on. So in the future, my guess is we will have a diagnosis for that. But FASD, for example, you could also put it under a developmental disorder due to other medical conditions. Or you could just put it as a developmental disorder. This, wherever it was, is the way I would describe using it is a lot of times we see patients who come in to us who have really a diagnosis of depression, or they have a diagnosis of PTSD, but they may also have, let's say, in their 60, okay, they have a history of maybe cerebral palsy as a child, or they come in and you're talking to them and you know they had problems in grade school, but now they're 60. And when you're talking to them, they just don't seem to be intellectually right there. You know, you suspect that if you did an IQ test, it would be under what would be considered an average range. So that would be the sort of situation you would use that under. So to explain that I don't have a formal diagnosis, I don't have enough criteria, but I'm telling you, my clinical impression is this person is not intellectually functioning at the level that they should be. So, make sense? Okay. Anything else? Okay. So here we are at section 3. This the fun section. Section 3 has items in it that seem to have initial support, but they require more research. So they're in that gray zone yet. There's enough there to think that it's going to get fleshed out, but not enough yet to say yes, we definitely have it. It's not part of an official diagnosis of a mental disorder, and it cannot be used as such. So, for example, internet gaming. You cannot use internet gaming. As much as in your heart of hearts, you believe it is a real disorder as a diagnosis. Interestingly enough, there's been a lot of talk through the years, especially the past 5 to 10 years, about sexual addiction. Sexual addiction has not even made it in DSM-5 as a separate disorder to consider. And why is that? Well, because there's still not enough hard evidence that sexual addiction can truly be moved out as something that is a distinct entity versus gambling disorder, versus internet gaming. Now, once again, you can doesn't mean you can't talk about it, doesn't mean you don't work with it, but you can't use it as your diagnosis because it's not considered an official diagnosis. So section 3 is broken up into emerging measures and models, assessment measures, cultural formulation, the alternative DSM-5 model for personality disorders, and conditions for further study. Dimensional assessment. What are we really talking about here? DSM-4 in many ways was very rigid. You know, you had to, things were sort of broken into boxes, right? What DSM-5 is trying to do is convey that there's a full spectrum in almost all of these disorders, that there is not a clean line that happens in most things. And that's what DSM is trying to convey. It includes information about depressed mood, anxiety levels, sleep quality, substance regardless of diagnosis. So if you look at your handouts, let's see, you will see that there's a handout called DSM-5 Self-Rated Level 1 Cross-Cutting Symptom Measure. Okay, this is right out of the DSM. So it allows clinicians to rate both the presence and severity of symptoms and allows for you to track the patient's progress. These are characteristics. So a level 1 assessment, this is what we're talking about right now. This is a level 1 assessment. Is basically, it's used to help in terms of prognosis, treatment planning, and outcome. But there's two types of cross-cutting assessments, level 1 and level 2. Level 1 is, if you look at the instrument, it's really a broad range of symptoms, okay? So it will not give you a specific diagnosis. It helps you narrow down where that patient seems to be having trouble, okay? So, you'll see it asks very general questions. And if you read through them, you can see what they're looking for. There's certain questions that are clearly focusing on depression, some on psychosis, some on suicidality. But none of that is going to give you a diagnosis. All it does is tell you what you're working on. And then you can go from there. Once you do level 1 and 2, you can do diagnosis-specific severity ratings, disability assessment, and they can either be from the patient, the informant, or a clinician. So the level 1, it's really symptoms relevant to most psychiatric disorders. I've only given you the adult one. There is also one in the DSM for children. Same sort of idea, but geared to children, okay? So let's say you do the level 1. So what? Then what do you do with it? Well, then if you look down to level 1, and anything that is mild or greater in symptom severity, you can then go to a level 2 assessment tool. It's obviously more detailed. It's largely based on already pre-existing, well-validated measures. These are just some examples of it. There are a ton of different scales that have been validated. And in your handouts, Table 1, this, once again, right out of DSM, gives you the idea of what they're talking about. So, if on your level 1 screen, let's say you come up with mania, you're looking at the symptoms look like they are manic. Well, then you could go down to mania, mild or greater, and you do a level 2 screen. The level 2 screen would be specifically and only to rate mania. If you got depression on level 1 and you were suspicious, then you go to an instrument that would only focus on depression, okay, and the range of degree of that depression. Now, these are all wonderful, right? And everybody thinks, and we all think this is great, and I think it's great. And don't you wish you had the time to do this with everybody? I mean, I think we all have to be, because when we start talking about these things, I think it makes us all nervous. Like on our day-to-day work, somehow now we're supposed to, with every patient that walks in the room, do a level 1 screening, and then we better have level 2 screening tools there, and we better have the time to do all of this. Well, this is all wonderful. And yes, it would be great if we could, but we can't. Okay? So what I would suggest is to realize that this is what they're doing with the research protocols. If we were in a university setting, and we had lots of research money, and we had lots of graduate assistants who were paying nothing because they're in graduate school, this is what we would be doing. Okay? But, so how do we use this in our everyday practice? What I would say is, depending on your practice situation, maybe you do the level 1. And, if you've got an office staff that they can just give the patient it, the patient fills it out themselves, it might help you do an initial level 1 screening. Maybe you've got a couple of level 2s in your back pocket, so to speak, that you personally feel are useful for your practice. And you might pick and choose certain patients to give those to, okay? But would you necessarily, and yes, you could, it would help you in terms of talking to the insurance companies and validating all of that, but you're not going to be able to do it with everybody. It's just not practical in most practices. I mean, the amount of administrative time that all of this would take, it's just not realistic. But I would say you reserve this sort of approach to realize this is what's recommended, and you reserve this for those really tough patients. Either the ones who you have questions about in terms of diagnostically, you really are kind of uncertain about what's going on with them, and use these tools to help you figure out those particulars. So you use it selectively, not just broadly. Or let's say you have a patient where the insurance company is giving you a hard time, or you know that they're going to give you a hard time, okay? And we all know who they are. I'm sure we all can name them. These are what I would do, because with those numbers, they're really hard for them to argue with you about. So that's the way I would use them on a practical level. Document the severity of specific disorder. They can be administered to individuals with, if they meet full criteria, other specified diagnoses. Some are clinician-related, some are patient-related, some are rated, some are both. There are certain ones that obviously you're going to have for caretakers. I mean, if they're children, they have to be parents, obviously. If they are people with neurocognitive problems, obviously you're going to either have to have an instrument that you can do or that you can modify, which is what the HUDAS allows you to do, and I'll explain that shortly, like now. So, so HUDAS 2.0. Here's the key phrase before anybody has a panic attack this morning. It is recommended but not required at this moment. Okay, and I am putting that, I am underlining that 3 times, at this moment. But, comma, now you take your Xanax. Be prepared that this is going to be used extensively and be used more and more, unless they come up with something else that's out there that's simpler to use. But so far, it's not mentioned. No other instrument is mentioned in the DSM. I have seen no other instrument mentioned in any of the articles I've read. So if there's another instrument out there they're considering, they're keeping it a really good secret. So, like I said, we may as well kind of get used to the idea, and then if something easier comes along, we can all breathe a sigh of relief. Like I said, this is based on the International Classification of Functioning Disability and Health. This is already used for all medical conditions and other health conditions. It's not a new instrument. And for example, if you're rating somebody for disability for a physical medical problem, they use this. So we're merely incorporating it now into mental health use. GAF eliminated, not officially replaced. The problem with the GAF, as we all know, was it mixed a whole bunch of different concepts. Interrelator reliability was horrible, and we all just picked a number that seemed somewhere in the right neighborhood, let's be honest. You know, if I went around and said, you know, you tell me what a 35 means and you tell me what a 40 means, I bet you we'd be hard pressed to get anything reasonably intelligent about that. So, so it's meant to use for understanding and communicating. So the sections are, these are the domains that the HUDAS covers. Understanding and communicating. How does somebody get around? What are their self-care skills? How do they get along with other people? Life activities in the household. Life activities in work or school. Now this one you would skip if the person does not work. Work can mean, though, paid, non-paid work, or self-employed. So let's say somebody is a volunteer of a significant degree. You can use that to have them rate this, okay? Or let's say they work for a spouse, but they don't get paid. Well, they're still working, okay? So, and then there's another part that's participation in society. So once again, it's really hard to argue with this instrument as something that's useful, right? I mean, we'd like to, but we can't.
Is it
So
for adults or for children also?
it is for adults.
Adult, that's what I thought.
Yeah, it's only for adults. There are 36 items, and you've got a HUDAS in the handouts. Once again, this is right out of DSM. It shows you all the questions and how they're phrased and related. So there are 36 items. The rating for each item is 1 through 5, no difficulty to extreme difficulty. It's supposed to be by the patient. You're supposed to give this to the patient, and they're supposed to do it. We, once again, can all think of lots of patients where that is not going to be possible, right? There is a provision that you, as the clinician, can go in and do a modified score for the person. And especially, once again, neurocognitive problems, there's no way. And you're going to have to do it in conjunction probably with their primary caretaker, whether that's a spouse or whoever. You should encourage the person to complete all the items. You calculate the average score for each domain and for the overall disability. So it's broken up into sections. One of those 6 sections, you calculate an average score for the section and then for the whole thing. And then the average scores are based on the point scale. So you get a raw score, you can get a maximum of 180 points, and you would then, to get your overall score, divided by 36, and that would give you your average, okay? Now, if someone does not answer 10 or more items, it makes the score, basically puts the score into question as whether how valid it is. So if they go through the whole thing and they don't, because 10 items is essentially 25%. So if they don't answer 10 items, then it's going to really make a question mark by how valid your HUDAS score is. But if the 10 or more items are clustered within a certain category, then you can rate those categories that they have answered. For example, let's say they complete 100% of life activities section, okay? But they don't complete anything in social participation. Well, you can score an average for life activities, but you wouldn't for social participation, and you couldn't for the overall score, the average score. Does that make sense? Kinda? Okay. So essentially the magic number is 10, and 10, anything 10 or above, you have to question the validity. If the 10 is clustered, you can take out those clusters and score the other areas. Culturally informed assessment. There's a huge section, and this is kind of what we got to a little bit earlier, on doing a culturally informed interview. Okay, there's a number of pages. It's very well described on how to do it. And what the DSM-5 is saying is that you should be culturally informed. Here's a big surprise. That you should be aware of specifically asking the patient's view of their symptoms, and not just a symptoms list. Is there a culturally specific way of defining the problem? There's specific background influences, whether it's cultural, ethnic, religious, geographic, racial, whatever. Do they have specific language for what they're describing to you that is specific to their circumstances? The cultural definition of the problem. What's the patient's point of view on what led to this problem? What's most troubling to them about it? What's the greatest concern? And the cultural perceptions of cause, context, and support. So what's the patient's understanding of the circumstances of their illness and what caused it? Once again, you can get some very, very unique answers to that question that are not psychiatric problems. It is merely the framework in which that person puts it. Once again, spiritual explanations. I'm thinking of like a lot of Caribbean islands and Caribbean traditions have some what we would consider very odd explanations of things, but they're not psychotic because it's just part of their belief system. What has the patient done to address the problem? What has been their most and least helpful? These two things in a Native American population obviously can be very important because they may have gone to, their local spiritual healer and, they've done ceremonies and you are a last resort, and you've got to understand where is that patient coming from. They are only coming to you because they feel like what makes most sense to them has failed them. In some ways it's no different than many of us believe in Western medicine, but sometimes we'll turn to Eastern medicine when we feel like we've gotten no relief from Western medicine, and therefore we're going to it as our last resort, not because it's really our primary choice. So that's the sort of thing to be very aware of. Their expectations of mental health care and perception of resources, this is a big deal. How many people come to you who are very skeptical of mental health care? Who really think, you're snake oil with a degree. And it's really important to understand that. What's their relationship with you? And what do they see as their barriers? As a psychiatrist, I get a lot of people who come in and are very skeptical. Yeah, my therapist said I should come and see you. As a matter of fact, they made me come to see you. But I don't believe in medication. Really? I didn't realize it was a religion, but that's okay. So, but you have to start for where the patient was from, right? And explain to them, you cannot just impose your years of experience on them. You have to kind of bring them from where they're at if you expect your treatment to succeed. Some people you can do that. Most people I think you can do that, to be honest. Are there people you absolutely cannot? Absolutely. And you need to know, and you need to realize that up front. Because then all you're going to do is waste your time, their time, and you're going to create false expectations. And you're going to be the next person in a long line of mental health professionals who failed them. This is just a very brief overview of what I'll talk about later. Like I said, this will be much more extensively covered later. The Section 2 model was a categorical model. The Section 3 model is a dimensional model. It reflects that personality disorders represent maladaptive variants of personality traits that merge imperceptibly into normality and into one another. Once again, it actually makes a lot more sense when you think about it than the current model. Here are the conditions for further study. So in other words, these are sort of the nominees for DSM-5, okay, if you want to look at it that way, okay. Attenuated psychosis syndrome, depression with short duration hypomania, persistent complex bereavement disorder. This is interesting because they've eliminated bereavement. So I'm not sure why it's showing up here, but it is. I guess somebody couldn't totally give it up. It's probably their entire research career has been spent on this, and they were on the committee, so they got to keep it. Caffeine use disorder, internet gaming disorder, neurobehavioral disorder due to prenatal alcohol exposure, fetal alcohol syndrome, suicidal behavior disorder, and non-suicidal self-injury. All those self-cutters out there. So, the appendix is a list of lists, many boring lists. So how are we supposed to use this book? So this is the general way that one is to approach how you use DSM-5 in the entire diagnostic process. Okay. So in making a diagnosis, the first thing you do is you're supposed to administer those cross-cutting assessments. So notice, suggested, not required. So you would do a level 1 assessment, and then if you felt appropriate, you would do a level 2 assessment. Okay? On a practical level, kind of what I would suggest is if it's easy for you to incorporate that level 1 assessment that's in the DSM, you would give it to the patient just like you do when they walk in the door with all their paperwork, and you let them fill it out. And you don't get too wound up about it other than that. And then whether you do anything with level 2, I would leave that up to you. You conduct a clinical interview, and I am still of the old school, I have to admit. The clinical interview, in my opinion, is still the most important thing. I don't care what instruments you use, I don't care what fancy numbers you add or subtract. I think sitting down with the patient is what's going to give you always the most information. You determine if you feel the diagnostic thresholds are met. And the way DSM does that is, you're supposed to go through and you do your interview and then you look at whether all the categories and all of that, and then you decide, right? Well, I think what you do is, in my opinion, you decide what you've got in front of you, and then you go to DSM and see which category it fits. So, or, and I will deny I've ever said this, you slightly alter the documentation so that you meet the criteria. If you've forgotten to add 1 or 2 of those symptoms, when you do your evaluation, you mention it in your evaluation. So what I'm saying is, don't be sitting there with the DSM-5 going, check, check, let's see, no, I missed that one. So. You then consider subtypes and specifiers. For some sections, this is quite significant. For all the mood disorders, there's now a large number of specifiers that were never there before, and I'll cover that in a little bit. Consider the contextual information, the course, the differential, the amount of distress, obviously your own clinical judgment. And then you finally make your diagnosis. You can administer your severity assessments. Once again, these are level 2, usually, assessments. You apply the codes and you follow their instructions. And once again, as you look under each of these sections, the number of codes under each of these sections will really blow your mind. I mean, because they get very specific and they get very redundant in some places. But ultimately, I think what's going to happen is, we all know we use, there's probably 20 or 30 codes that we really use most often. And we're going to learn those very quickly. And then in those other cases, you'll have to go to the book. You then go to the HUDAS, which is suggested, not required, until the moment the insurance companies realize they can ask for it. And then you develop your treatment plan and your outcome monitoring.
A question?
Yes, sir.
Maybe I missed it. What happened to borderline personality disorder?
It is, borderline personality still exists in DSM-4 under personality disorders. And I use borderline personality disorder in my talk on personality. So I will specifically go over how it looks different in the alternative model, because I thought that's one that all of us could relate to. Now, once again, take a Xanax. There's dual coding provided for a period of time now, because there is a delay between DSM-5's publication and ICD-10. Okay, so ICD-10 is supposed to be coming out this fall, but all the insurance companies, who knows when they're going to get their software up, so just expect glitches, okay? Some codes, the same code may be used for multiple diagnoses. In select places, there are unique codes for subtypes and specifiers. For neurocognitive and substance medication-induced disorder, the coding depends on the specification. All of that means that it can be quite complicated, and if you just look under each section, it is pretty easily spelled out, okay? Now, substance use disorder, remember we had to make that distinction between abuse and dependence in the past. Now, what we can do is we can indicate substance use disorder, mild, moderate, or severe, along a continuum based on the number of criteria that are met under substance use disorder. It's actually a much, much more reasonable and logical way, and I think practical way of dealing with the disorder. The other thing with it is you can slide up and down that. In other words, if somebody was severe and they've improved, you can bring them down to moderate by changing the code number. So it's in many ways a far more flexible model. All right, what else should I want to say about that? APA that's the American Psychiatric Association, is working with insurers to ensure that these are recognized as distinct entities. I wish them lots of luck. So, insurance considerations. There may be a delay in updating their coding systems. Remember, everything is done through the computers now. God knows when they're going to get their computers to match what we're supposed to be doing in the real world. There may be delays in removing the multi-axial system. So even though we're not supposed to use it, all of their templates, all of those people who call you and say, I'd like to do a review with you, or all those forms you get that you're supposed to fill out to justify why the person needs therapy, for a long time, they may still show the Axis 1 through 5 diagnosis. In place of Axis 4, use the VZT codes and the HUDAS for Axis 5. Now, of course, the government has come to our rescue by giving us this very simple place to go. This is and I'll leave this up over lunch so that people, if they really want to copy it down, they can. But this is CMS's, for more information about DSM-5 and ICD-9, if you've got questions. And I'm laughing because could you come up with a more complex way of doing this? I mean, really. And so, like I said, I'll leave it up during lunch if people want to copy that down. All right, new diagnoses in DSM-5. Premenstrual dysphoric disorder is in ICD-9 and 10 premenstrual tension syndrome, okay? So they this is our diagnosis in DSM-5, but they use the coding numbers of ICD, just to let you know. Hoarding disorder. We have it now as a separate entity, but in ICD-9 and 10, it's still classified under OCD. Okay, so these are the sort of problems you're going to come into looking at. Binge eating disorder is still called bulimia nervosa in ICD language. Alcohol-related disorder, called alcohol use disorder, which is the old alcohol abuse and dependence combined. Alcohol intoxication, alcohol withdrawal, other alcohol-induced disorders. Once again, that's if you don't feel like you meet the criteria for an alcohol use disorder, but you still know that's what this really is, and you can specify it. Unspecified alcohol-related disorder. That's if you don't think you have enough criteria, but you still think it's a problem, and you don't want to say why. Here are the coding examples. So, if it's a mild alcohol use disorder, you need to have 2 to 3 symptoms of the list. This is the code that you use. This is the ICD code. If it's moderate or severe, so 4 to 5 symptoms or 6 or more symptoms, notice the coding is the same. Okay, once again, just adding to some of the confusion regarding coding. And it's the same in F. So there's a distinction in how you clinically talk about it, but the coding distinction is only bifurcated. You then would specify, which is not in the coding, but in when you would write it out. So you would say, alcohol use disorder, comma, moderate, comma, in early remission, meaning they've been not using for at least 3 months, but less than 12. Or sustained remission means they have been abstinent for at least 12 months. Okay? So, once again, it's alcohol use disorder, comma, moderate, comma, in early remission, comma, if it's in a controlled environment. So if someone's in prison, and they have been sober for 2 years, that's grand, except if you specify in a controlled environment, because it was not their own free will. Yeah.
Is there going to be more polysubstance at all?
There is a separate category for polysubstance, yeah, absolutely. So here's some of the examples I just gave. Alcohol use disorder moderate in sustained remission in a controlled environment is F1020. Alcohol use disorder moderate is still F1020. So once again, there's a difference between what the codes are going to really tell you versus what you write out. So as a clinician, what that really means to me is what we write out is going to be far more useful to us than just looking at the code numbers. Okay? The code numbers really are what we're using for insurance purposes. But for real documentation in the medical record and in your notes, what's really going to be important is how you write it out. And the more specific you get, the better. Let's see, you don't use the previous codes if alcohol intoxication, alcohol withdrawal, or other alcohol-induced mental disorder is present because they're separate entities. I keep laughing because some of this is just so crazy. Comorbid alcohol use disorder is indicated in the 4th digit of the alcohol-induced mental disorder. So once again, all I'm trying to convey here is when you are really sitting down with this, you will learn how to code appropriately. Hopefully, most of you have billing people whose entire life is spent knowing this stuff. But if not, like I said, I think what you'll come up with is you'll learn the ones that you need to know. ICD-9 code for alcohol intoxication is 303.00. But when we go to 10, alcohol intoxication is going to depend on the comorbid alcohol use disorder. So once again, you see there's a distinction that they're going to change in 9 and 10. This is coding examples for major depressive disorder. And what I've done is I just picked a couple of things to use as examples of things that are very common that we run across every day and how DSM is going to handle it. So you start with severity, mild, moderate, or severe, based on the criteria. You then talk about episode. Is this a single episode or recurrent episode? Then you do course with psychotic features, in partial remission, in full remission, unspecified. And all these combinations have different codes. So these are just a couple of examples. Major depressive disorder, single episode with psychotic features is 296.24. But major depressive episode, recurrent severe, is a different code, of course. That's 296.33. So once again, I think what the practical way of doing it is you make the diagnosis, you put in the descriptive elements that make clinical sense to you, and then you go to the book, and the numbers should pretty much pop up to match it. So when you do a diagnosis in depression, this is the order that they should be, the descriptive word should be in. Whether it's a major or depressive disorder, single recurrent episode, the severity of it, followed by as many specifiers. And here they come, the list of specifiers. So at the very end, after you've done all of that, then you can specify now with anxious distress, with mixed features, with melancholic features, with atypical features, with mood congruent, with seasonal pattern, with mood incongruent psychotic features, with catatonia, or with peripartum onset. So, that's a lot, but if you think about it, once again, if you're sitting there with the patient, it makes very good sense, right? So let's say you've got somebody with postpartum depression, right? So, what would you diagnose? Let's say it's their first episode, right? You could diagnose major depression, single episode, moderate, let's say their symptomatology is her symptomatology is moderate, right? But how did you convey before that this was a postpartum or peripartum depression? It was very difficult. There's no specific diagnosis for that. So now what you do is you add with peripartum onset. So when the next clinician picks up the record, or somebody requests the medical record, if they look at the diagnosis, they know immediately this was a postpartum or peripartum depression. So it's actually very useful. The coding number this is not reflected in the coding number, but it's very clinically useful. How about a seasonal affective disorder? We had no diagnosis for seasonal affective disorder. If you wanted to know that just by the diagnosis, there was no way of figuring that out. You had to go to the record and read the patient's record. Now, you add with seasonal pattern, and you've already told the person either that it's a seasonal affective disorder or there's a huge seasonal component that's affecting it. So there is a lot of utility. How about all those patients with depression who are also anxious? Tons of them, right? And you sat there as you're trying to make the diagnosis thinking, do I say major depression? Do I say major depression and generalized anxiety disorder? Do I say generalized anxiety disorder but put a major depression second? No more. You can say, if the symptoms are predominantly depression, but there's a significant amount of anxiety present, then you say major depression, single or recurrent, mild, moderate, or severe, with anxious distress. And you've now just explained to the next person what the general characteristic is. And if the person then presents, or let's say you don't see the person then for 3 years and they come back, and they walk in the room and their presentation, you're like, well, I remember this person, I remember they were depressed, but I'm not sure their presentation is exactly the same. Well, let's say they come in this time and they really aren't that anxious. Well, if you go back and look at your old diagnosis, you'll know immediately that that person in the past was really depressed. This presentation is different because you're not seeing that, and it's already triggered it by what you've done. So there is some very clear clinical utility in using these diagnoses. Major depressive disorder, they dropped the bereavement exclusion, the addition of the mixed specifiers, the addition of the anxious distress specifier. The DDNOS becomes either other specified depressive disorder with a specified reason added. In other words, you would say other specified depression with insufficient, with 3 of the 4 criteria met, or you would explain it more. So you'd explain why you're using other specified. Unspecified is because you don't want to explain why you're not giving them the whole diagnosis, is basically it. How many people want to raise their hands saying insurance will never pay for these diagnoses? Okay, so we may as well get used to this as basically like the NOS was, which will never use them. Bereavement. This is, we've dropped bereavement, okay? Does that mean bereavement doesn't exist? No, okay? And as you see in the section 3, it might be coming back in a different version. But what is important to realize is bereavement exists, and it exists in conjunction with major depression. And the problem with the old version was that it made it sound like you couldn't have both. And you can have both. And there was usually this exclusionary period early on where bereavement would supersede, in some ways, you diagnosing somebody with major depression. And that was a problem. So just quickly to go through what the difference is. Bereavement is characterized by a sense of emptiness and loss. The dysphoria decreases in intensity over days and weeks, and it comes in waves associated with the reminder of the person who has been lost. Okay? The thought content is generally characterized by preoccupation with thoughts and memories of the deceased. The self-esteem of the person is usually preserved. And if thoughts of death and dying are present, it is death and dying regarding joining the deceased. Okay, so what's the easiest way of remembering what bereavement is all about? Bereavement is all about the other, okay? It's not about the self, okay? It's about the other. I've lost my partner. I've lost my wife. My thoughts, every time I think of them, I get sad and depressed. Every time I find one of their pieces of clothing, I become sad and depressed. I want to be with them, okay? That's different than having a major depression. A major depression associated with bereavement is a pervasive depressed mood. They cannot anticipate happiness or pleasure, and it's not tied to the specific thoughts of the person, okay, which is a very important thing. They're not saying, a lot of people you'll hear in bereavement will say, gosh, I can't imagine ever enjoying another vacation without Martha, because Martha and I always traveled, okay? That's different than saying, I can't ever imagine enjoying anything again for the rest of my life. Okay, there's a very distinct difference between those two. The thought content is self-critical or pessimistic with low self-esteem and a sense of worthlessness. So, once again, a very clear example. You hear lots of people in bereavement say things like, gosh, did I do enough? Did I stay with him enough? Did I care for him? Should I have gotten that extra opinion? Things like that. But people who talk about saying with the person, I'm totally worthless. If I had been a better wife, then I would have been able to let him live longer. Okay? I am just so inadequate when it comes to being a caretaker. So that's the difference between one versus the other. And then the thoughts of death and dying are thought of ending one's life because of a sense of worthlessness, being undeserving, or being unable to cope with the pain of the depression. So, in other words, it's not about, I want to be with Martha. It's I-focused. I don't want to be in pain anymore. Okay? I don't deserve to live. So once again, it's the frame of reference the person is coming from. Now, can both be present? Absolutely. Absolutely. But if you've got a major depression associated with bereavement, if you do not treat the depression, it can complicate and prolong that person's ability to work through the bereavement. And that can last for a very long time. And that's why it was really important to make this distinction. Because lots of people were saying that, well, they would say, oh, that person's, grieving. So we really shouldn't worry about treating that depression because that's normal. No, bereavement is normal. Major depression is not. And one should make that distinction. Where does this most likely occur? Well, big surprise, it occurs with people who have already histories of major depression or family histories of depression. It's genetically influenced. People who have both generally have similar personality characteristics, comorbidities, chronicity. So once again, you look towards their past history to help you figure it out. DSM-5, it implied that bereavement only lasted 2 months because then it became a depression. Obviously, that's not true. Bereavement can last 1 to 2 years easily. It's severe psychosocial stressor that can precipitate a major depression. Once again, they are not mutually exclusive. And that depression adds to the person's suffering, it adds to their worthlessness, it adds to their suicidal risk. Their overall health is further compromised. I mean, frequently if you've got an elderly person who's who has a major depression and bereavement, and they have cardiac problems, that increases their stress. That can make their cardiac problems worse. It can make their hypertension worse. Stress increases their diabetes. So it is not a minor issue to kind of sort out. Postpartum depression has been changed to a postpartum specifier because MDD can occur during pregnancy as well as during paratresion. In other words, now, it's usually about within 4 weeks of delivery, but we do recognize that it can happen. It's not just immediately afterwards. The other thing to remember with postpartum depression is it can occur up to 1 year after delivery, okay? 1 year, and we sometimes forget that if you're in month 6 or 7, we think, oh my gosh, that was a long time ago, the kid's getting older, they're sleeping through the night, so it can't possibly be postpartum depression. Not true. Absolutely not true. So, depressive episode with mixed features, another one of those specifiers. These are those people who would come in and we would talk to them and you'd be like, is this person bipolar? Are they bipolar type 2? Are they hypomanic? Are they anxious? I don't know what they are. Well, what they frequently they were depressed, but they had a bunch of other symptoms that was confusing the clinical picture. And now we're not forced to put them into it because we don't feel like we have an adequate diagnosis to slot them into another place. So we don't have to, call them bipolar type 2 because they have several of these features. Now, could they be bipolar type 2? Sure. But do you feel confident enough to diagnose that? Maybe not. And we all know that it makes a huge difference for those of us who prescribe what medications you're going to use. And it makes a huge difference when once again, these medical records now, yes, we have HIPAA and they're all private and blah, 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 blah. But we all know that's not true, right? We all know once you've given somebody a diagnosis, they carry it with them forever. It's really rare to see someone's diagnosis taken off of their record. So rather than label somebody bipolar and they're not, you can use this to indicate that you have a different clinical picture than a simple depression, but that it's not a clinical picture that you're confident enough yet to call a bipolar disorder. Or you're not confident to split it into an anxiety disorder and a bipolar disorder. Anxious distress, same idea. Once again, no, you don't need 2 diagnoses. If you think, God, this person's depressed, but do they also have an anxiety disorder? You can now use a specifier to clarify that what you're seeing is someone who's depressed that looks really anxious also, but you're not confident or willing to say that they have 2 disorders. So, once again, you're helping clarify the clinical picture. All right. Any questions about any of that? Because this is the end of part 1. Half an hour late, but that's okay. So this is the overall structure and use of DSM-5. So we're going to start going backwards. And we're going to do personality disorders. So this is the DSM-4 DSM-4 and current DSM-5 way of diagnosing personality disorders. Okay, they're in clusters. Cluster A, paranoid, schizoid, schizotypal. Though remember what I said about in the schizophrenia spectrum. There's another way of doing that. Cluster B, antisocial, borderline, histrionic, narcissistic. And in C, avoidant, dependent, and obsessive compulsive. Pretty boring. We all know these. They all are sort of, yeah, we talk about them, we use them, but how often do you really use those diagnoses? Probably practically never, right? They are very rigid. They tend to be stigmatizing. And even though they might be useful, once again, we don't like labeling patients because once it gets on the record, every health professional picks it up. Suddenly that person is X, and the door shuts on a lot of things for them. So we don't use them, basically. And then there in DSM-5, there are these other personality disorders, which are personality change due to another medical condition. What would those other medical conditions be? For example, personality disorder due to multiple sclerosis. okay, as an example. And then you would so you would say personality change due to another medical disorder, comma, multiple sclerosis, comma, then you would try and specify what type. So has the person become more aggressive? Has the person become more paranoid? Have they become more passive? Whatever, okay? And so this is what you would use. Obviously, this in a medical setting would become something that you would see a lot. Other specified personality disorder and unspecified, same idea. NOS broken into two different things, probably you'll never get paid for them. So, all right, so in 4, or in 5, I'm sorry, so the 10 personality disorder sections are unchanged from DSM-4. They're exactly the same. The only difference is now you don't put them on Nexus 2, you just put them in the list, okay? So, but it's really kind of boring. But why do we care about personality disorders? Because they're prevalent in clinical settings and in the general population. There's a high degree of social and occupational impairment, both in role status and quality of functioning. They predict slower recovery, more likely relapses, greater chronicity of other mental disorders, specifically anxiety disorders, mood disorder, especially depression, and substance use disorders. And they are very costly to society. So anything that we're talking about as a primary psychiatric disorder, if you have a comorbid personality disorder, it is more complicated, more difficult to treat, and it is a problem. So we'd like to define the problem a little bit better. So what were the problems with DSM-4? Well, the criteria for DSM-4 personalities are very nonspecific, and there's no real empirical basis. In other words, yeah, there's been some studies done with them, and yeah, interrelated reliability, but they're not real clean by any stretch of the imagination. They co-occur, so they tend to overlap a lot. So what you might call borderline overlaps with narcissistic, with overlaps with antisocial. How many times are you in a clinical discussion about someone's personality, and you might start out saying they're borderline, and you're finding yourself sliding all around from narcissistic to antisocial, and by the time you finish talking about it, you've said absolutely nothing useful. So, there's extreme heterogeneity about it. The criteria content are inconsistent. Once again, that's sliding around in those areas. A lot of instability and incompatibility with the basic definition. They're arbitrary diagnostic thresholds. So, you know, I may call somebody a borderline because I think they've reached a certain level of severity. You may call them a borderline at either a greater or lesser level of severity. And a lot of times, especially in medical settings, we all know that the first criteria for calling someone a borderline is you're frustrated with them, right? The minute someone is frustrated with them, you know, they're borderline. You know, so that's a problem, okay?
Except it's usually right.
That's true. Let's see, poor coverage of pathology, poor convergent validity, meaning two people making the same diagnosis, not real good. And limited predictive validity and clinical utility. In other words, even if we both agree this person is borderline, because of all these other things, it doesn't help us a whole lot in what's their course going to be, what's their, what treatment plan should we put in place, what tools should we use, doesn't help us. So what they tried to do, or what they're trying to do in section 3, is they are trying to make a clearer conceptual basis for personality disorder pathology, make it more efficient and effective in assessment, and more empirically based in formulation of criteria. That all sounds wonderful until I start showing you what they're trying to do. So, this new hybrid alternative dimensional / categorical model, the name alone tells you where we're going, okay? So it's like an equation on how you now will, and how in section 3 you will diagnose this. So the first section is moderate impairment in personality functioning. Okay, so here's the key word, personality functioning. And that, when you look in the DSM section 3, there will be criterion A. Criterion A is all about personality functioning. Okay? Criterion B is all about personality traits. So A is personality functioning, B is personality traits. Okay? And then you take into account relative stability, consistency, developmental, cultural, substance, and medical exclusions, which is a lot. That's criteria C through G. Okay? And then you finally get to make the diagnosis. Okay? Now, criteria A and B are different depending on which of the personality disorders you are diagnosing. In other words, there's a menu of A and there's a menu of B, but for borderline, certain elements for personality functioning will be highlighted for borderline, but those will not be the same elements that would be highlighted for antisocial. That's how they come across as different. As is true for the personality traits. So personality traits that you find that are diagnostic of borderline are going to be different than what you find diagnostic of antisocial. All right, so what do I mean by all of that? So there's 5 levels of personality functioning that address the self and interpersonal elements. All right, stay with me here, okay? Don't glaze over yet. Okay, so big headline, criterion A, okay? Big headline. Little headline over here, level of personality functioning 1. Okay, so remember, criterion A is all about personality functioning. They broke that into 2 levels. They call level 1 and level 2. Level 1 is composed of the first part of level 1 is self. Okay, so the person's sense of self. And the second part of level 1 is self-direction. All right, does that make sense? Personality functioning, level 1, broken into self, and then I'll show you the next one, but self is identity and self-direction. So what's identity? Well, that's the experience of oneself as unique, with very clear boundaries between self and others. The stability of self-esteem and accuracy of self-appraisal, and the capacity for and an ability to regulate one's emotional experience. So that's how they're defining a sense of self. Self-direction. That's the ability to pursue a coherent, meaningful, short-term and long-term goals, life goals. And the utilization of constructive and pro-social internal standards of behavior and the ability to self-reflect. Okay? So, once again, when you're thinking of personality, this is one part of the functioning. So self is broken into identity and self-direction. The level 2, once again, we're still on criterion A. This is same line, level 1, those 2 things. Level 2, these 2, empathy and intimacy. So one's ability to empathize with others, comprehension and appreciation of others' experiences and motivations, tolerance of differing perspectives, understanding of effects of one's own behavior on others. And then intimacy is the ability for the depth and duration of positive connections with others, the desire and capacity for closeness, and the mutuality of regard reflected in interpersonal behavior. So, if you think about the way we look at personality disorders, they all make sense. It's the way we're putting all these pieces together. So just to flip back, so you've got criterion A, 2 aspects, self and interpersonal, okay? Under self, you've got identity and self-direction, and under interpersonal, you've got empathy and intimacy. So you're going down the line, okay? there is a level of personality functioning scale, of course, we have to have a scale. The scale is rated on the vertical axis 0 to 4. Okay, 0, 1, 2, 3, 4. Okay, on the horizontal scale, you have got identity, self-direction, empathy, and intimacy. And they're up here. Okay, 0 to 4, those 4 things here. And in each of those boxes is a descriptive element of what is a 0, under identity look like. And it will describe that. And then you go through and you can rate the function, that person based on those things. Now, that was just A. Okay, we've gotten through A, and I'm sure it's crystal clear and you're ready to go out and use it tomorrow. Then we get to B. Okay, so A is functioning, personality functioning. B is personality traits. Okay, personality traits are divided into domains and facets. Okay, because we can't keep it simple. So there are these 5 domains: negative affectivity, detachment, antagonism, disinhibition, and psychoticism. Okay, and what I put is one end of the spectrum is negative affectivity, the other is emotional stability. Detachment versus extroversion. But they're usually referred to by these here. So, personality traits, 5 domains. Under each domain, then, you have trait facets. Okay? So, remember that negative affectivity, going back, was the first personality trait domain, right? So, if we want to then look at negative activity, then we have 7 characteristics under negative affectivity: emotional lability, anxiousness, separation anxiety, hostility, depressivity, submissiveness, and perseveration. Okay? Each of those then have a definition, of course. So, as an example, so we're now, remember, reorienting you, bringing you back to the roadmap. We're in criterion B, personality traits. We are in domain of negative affectivity. Okay, so what is negative affectivity? Frequent intense experiences of high levels of a wide range of negative emotions and their behavioral and interpersonal manifestations. Okay, so that's what this domain is defining. Under that domain, the first facet is emotional lability, which is unstable emotional experiences, frequent mood changes, emotions easily aroused, intense and or out of proportion to circumstances. So that's just the first facet. Okay, remember there are 6 others under this domain. Okay, and of course we have a way of rating those because we need a number, right? So, when this is all said and done, and they put all these different parts together, the alternative model has 6, not 10, personality disorders. This is what you're left with: antisocial, avoidant, borderline, narcissistic, obsessive-compulsive, and schizotypal. Okay? Clearly, schizotypal we're still confused about because it keeps showing up in all these various places. And then you have another one, which is P, personality disorder trait specified. What is this? This is the equivalent of NOS, right? This is, I've got a little of this, I got a little of that, I don't meet criteria for any of them, so I'm going to call them this, okay? And that's what I'm going to do. So that's what Sections 3 model ends up with. So what is the supposed advantage of this? It supposedly, this I find hysterical, it supposedly decreases the burden on the clinician. I'm still not quite sure how that is to be the case, but I think what they mean is that this is supposed to be more objective. And so it leaves less up to the clinician's judgment and you can objectify things a little more. I'm not sure I agree with this, but that's what they're telling us. This is sort of a summary. So once again, criteria of personality functioning, moderate or greater in 2 or more, level 1, self, identity and self-direction, level 2, interpersonal empathy and intimacy, on a scale of 0 to 4, and each level of impairment is described for each of the 4 areas. Criteria B, for each specific personality disorder, there are various pathological personality trait domains and facets highlighted as, quote, must be present and or characteristic to make the diagnosis. So out of all those things I listed, that's how you make a specific diagnosis based on that. Specifiers may be present under each specific personality disorder to record additional personality features, and that's going to be dependent on which personality disorder you're talking about. Criteria C through G, believe it or not, are all the same for every single personality disorder. And I'll go over those very quickly, and it'll make sense why when you see them. So here's the example everyone's been holding their breath for, borderline personality disorder, right? Our bread and butter in many ways that complicate our lives. So criteria A, moderate impairment or greater in personality functioning manifest in 2 or more of the following 4 areas. Okay, this wording is basically how all the criteria made for all the personality disorders starts. This is different depending on which personality disorder. So identity, markedly impoverished, poorly developed, or unstable self-image, often associated with excessive self-criticism, chronic feelings of emptiness, dissociative states under stress. Self-direction, instability in goals, aspiration, values, or career plans. Now, does this sound like a borderline? Right, it does. It very much does. And obviously, whether you rate them 1, 2, 3, or 4 is going to depend on how severe these things are present. But you have to admit the description is pretty darn good for a borderline. So then we go to empathy, comprised ability to recognize the feelings and needs of others associated with interpersonal hypersensitivity, big bells should be going off, perceptions of others selectively biased towards negative attributes or vulnerabilities. And then intimacy, intense, unstable, and conflicted close relationships, marked by mistrust, neediness, and anxious preoccupation with real or imagined abandonment, close relationships, often extremes of idealization and devaluation, and alternating between over-involvement and withdrawal. It's a great description, right? So when you put all those, and that's just criteria A, but when you put those all together, if you really think about DSM-5's current model and this proposed model, this description really captures much more of what we deal with on a day-to-day basis. And then you would rank them depending on the severity of the personality disorder. So I do think it's a major improvement. So now we get to borderline personality criterion B. 4 more of the following 7 pathological traits, including at least one of impulsivity, risk-taking, or hostility. Once again, this varies. These required ones vary depending on which personality disorder you're talking about. But they all have these, what I would consider core features, core facets, that when we talk about, oh yeah, I have that gut feeling, well, what are we talking about? We're picking up on some of these things. Here are some of the areas that they're talking about. So emotional lability, anxiousness falls under the domain of negative affectivity, separation and security under the domain of negative affectivity, the facet of depressivity under negative affectivity, impulsivity under the domain of disinhibition, risk-taking under the domain of disinhibition, hostility under the domain of antagonism. And like I said, each personality disorder has the same basic layout, but the specifics are different. And once again, it sounds like a borderline, right? Exactly. So now, everything from C on is the same for all personality disorders, regardless. So C is impairments in personality function and personality trait expression are relatively inflexible and pervasive across a broad range of personal and social situations. So in other words, once again, it's your basic, this is personality. This is not a reaction to something, it's not a developmental issue, it's pervasive. The impairments in personality function and the individual's personality trait expressions are relatively stable across time, with onsets that can be traced back at least to adolescence or early adulthood. So in other words, this can't just show up when somebody's 40. One basic principle of personality disorders. What I find it interesting is they let you go back just to adolescence. They don't make you go back farther, which I think most of us usually think about doing. The impairments in personality function, the individual's personality trait expression are not better explained by another mental disorder. In other words, they're not depressed, which can alter someone's personality. They're not bipolar, that sort of thing. But remember, a borderline can be depressed and a borderline can be bipolar. They're not mutually exclusive. The impairments in personality function and the individual's personality trait expression are not solely attributed to the physiological effects of a substance or another medical condition. For example, if somebody has a traumatic brain injury, if somebody is an active alcoholic, you cannot technically if they're actively drinking, you cannot diagnose them with a personality disorder while they are actively using. Okay? It's a different story once they've sobered up or cleaned up. The impairment in personality functioning of the individual's personality trait expressions are not better understood as normal for an individual's developmental stage or sociocultural environment. So once again, we're going back to the overall concept of DSM-5, which is taking into account developmental stages in life, that people behave differently at different stages, and one's social and cultural environment. So in other words, what is normative for a 15-year-old is not normative for a 35-year-old, right? So the borderline who comes in behaving like they're 15 with their relationships, right? I'm in love 1 week, 2 weeks later, they're devastated because their boyfriend broke up with them. 2 weeks later, they have a new boyfriend who's the love of their life and everything will be wonderful. That's fine if you're 15. That's normal for 15. That's not normal for 35. So that's what this is talking about. Substance-related and addictive disorders. So over the past 2 decades, this is one of those areas where there has been a huge amount of progress made in substance-related and addictive disorders. Both in cognitive neuroscience, brain imaging, epidemiology, and genetics. We all know that there's still a huge, huge prejudice out there about alcoholism and substance abuse, that it's, character failure, that one has control over that, blah, blah, blah. There's a lot of evidence now that suggests that is absolutely not true, that there are real biological basis for it. And that's what DSM-4 is trying to convey. The reason for the changes is that the research showed that people with symptoms of substance use do not fit neatly into 2 categories. In other words, abuse and dependence. And I think we all ran into that all the time. And that there are different levels of severity. So one of the advantages of the new criteria is that it will allow us to intervene at lower levels of severity and hopefully get reimbursed for that. Because you don't have to wait now until someone is so severe that they would have qualified for a dependence diagnosis. You could hopefully get intervention paid for if you do a mild substance use or a moderate substance use disorder. Addiction had cultural implications. It obviously had stigma with it. Substance use disorder is meant to convey that it's a chronic progressive problem, that underlying brain circuits that may persist beyond detoxification, particularly the limbic system, are involved. And that the disorder is based on a pathological pattern of behaviors related to substance abuse that allows for a continuum. So once again, the way we've always clinically experienced it. So there is a single dimension, mild, moderate, severe, no longer abuse versus dependence. The diagnostic threshold is only 2 symptoms for mild. So once again, hopefully this will allow us to get involved with a lot more preventative programs. Dependence refers to pharmacological dependence, not a disorder. In other words, this used to be a diagnosis dependence. Now it is merely the physiological consequences of using a substance on a regular basis. So, there was a criteria that there had to be some involvement with the legal system in DSM-5 in one way or another. That's been dropped. Okay? There was no criteria that had to do with craving in 4, and that's been added to the criteria. Gambling disorder is now grouped with the substance use disorders, but it's in a separate subheader called non-substance use disorders, but it's in that chapter. So if you'll notice, it's titled Substance Use Disorder and Addictive Disorders. Gambling is the only addictive disorder right now, but it is the lead one of starting this new way of looking at certain behaviors. Added to section 3, internet gambling, or internet gaming, neurobehavioral disorder associated with prenatal alcohol exposure, fetal alcohol syndrome to most of us, caffeine use disorder. This is fun to just read, because I think this is hysterical to me, because I think 90% of the population has this problem. I mean, the way they define it is really quite severe, but it's still an interesting concept that I'm not sure what to make of it, but it's interesting nonetheless. And then they did add cannabis withdrawal. So what are the criteria? Tolerance to a substance. It doesn't count if a practitioner is prescribing the medication. So in other words, if somebody has chronic pain, they're getting opioids for their chronic pain, they can develop a tolerance to it, but if they are following the practitioner's directions, in other words, they're not abusing the medication anyway, they're not overusing it, they're only using it for the pain, they're not using it to go to sleep, to escape, that's okay. But if they are tolerant, but it's not based on a prescription, that's a different story. Withdrawal, same idea with withdrawal symptoms. So if a practitioner is giving a patient medication like a benzodiazepine, that we know if they stop it, they will go through withdrawal, that alone does not meet this as a criteria. It only meets it as a criteria if they are using the medication or that substance in such a manner that is not according to the way it's prescribed. Okay? That there's more use than intended, that there is craving for the substance, that the person has tried to cut down but cannot, so they've acknowledged in some way that there's a problem, that they spend excessive time in trying to get or use the substance, they give up activities because of the use, there's continued use despite negative effects, they fail to fulfill major role obligations, there's recurrent use in hazardous situations, and there's continued use despite consistent social or interpersonal problems. So those are the criteria that you look at. Then there are specifiers, of course. Early remission, abstinence, at least 3 months. Full remission, no symptoms for 12 months. Maintenance therapy specifier, those are for those people, for example, who are on Suboxone or Methadone. They would be under that. In a controlled environment, prison is the most common example of that. So it's, in other words, yes, they're sober or they're abstinent, but it's really not of their own free will. So, substance-induced disorders, intoxication, obviously this is acute use, withdrawal, that the person has been chronically using, they've developed a tolerance to the medication, and therefore when they present to you, they've stopped using it, but they have symptoms of withdrawal at the time of presentation. Other substance/medication-induced mental disorders. For example, substance-induced psychotic disorder, depressive disorder, These are in each of the depressive disorders or psychotic disorder chapters. So no more abuse dependence. So of all those things, those criteria I listed, all you need is two. Two of all of those things to have a mild substance use disorder. It's a pretty low bar when you really think about it. But the good part about that, it's a low enough bar that you can bring it into therapy legitimately at an early point and raise a flag about it, which I think is a much better utility, because people would react very strongly right away when you would say to them, well, you're dependent, or you have a substance abuse. Well, you can say, yeah, you have a problem, but it's pretty mild, and let's look at that. So then moderate and severe. The severity you can change over time. So that patient that starts with mild, and over 6 months or a year, you see them shift over to moderate. Once again, you can change the diagnosis, but you can also use that therapeutically. And then there's a modifier, is agonist maintenance utilized for moderate to severe opioid use disorder? This is a theoretical question that has not been resolved. And this comes mainly within the opioid disorders. Who do you put on methadone or Suboxone, and who do you not? There are all sorts of protocols, there are all sorts of criteria out there, but no one has really figured out how do you pick out that person who really needs this and who doesn't. And that's what's still sort of open to question. Diagnostic changes allow for earlier recognition and treatment, and specifiers allow for noting growth or regression as a result of treatment. So these are easy to go through because they're all the same. So this is, if you'll notice, alcohol-related disorders. There's alcohol use, intoxication, withdrawal, other, unspecified. Caffeine, intoxication, withdrawal, other, unspecified, mainly because I don't think you can become intoxicated with caffeine. Or you, at least at the moment, you can't withdraw from it. But all of them are structured exactly the same way depending on the substance. So cannabis-related disorders, same idea. Okay? Hallucinogen and phencyclidine, there are a bunch of them, but once again, if you look, they're really the same. Use, intoxication, perception, they all meet the same structure. So you don't have to feel like you're learning a gazillion new things. Inhalant, opioid, sedative, hypnotic, anxiolytic, stimulant, tobacco, other, or unknown, and that's it. So let's talk about gambling disorder. How come gambling disorder gets to be special? And how come it made it in as a diagnosis? This is sort of the research that has been able to make it rise to the level of an actual diagnosis. Okay, and it is, once again, the only non-substance-based disorder in DSM-5. Okay, it is strongly comorbid with substance use disorders, pathological gambling, and antisocial disorders. Pathological gambling is the term that we would use, when people had gambling problems before, when there was no real diagnosis. So it's a level of gambling that would fit the degree of problem it is in the person's life. There's actually genetic literature where there's a behavioral disinhibition is a measurable phenotype with high heritability that underlies antisocial disorders, substance abuse disorders, and gambling. So these three guys down here, traveled together. And so the question from a genetic standpoint is this different manifestations of one underlying genetic problem? Okay, and that's at least the current thinking, even though they haven't worked out all the genetics. There is a considerable amount of evidence for shared neurobiology, that there's an imbalance of motivation and reward systems versus the inhibitory systems regarding those, much like the substance use problems. May improve crosstalk. In other words, they think this has been raised to the level where by making it an official diagnosis, they are encouraging more animal and clinical research, and there's not enough of a basis there for that to be happening, for us to be spending money and time doing that. So what are the criteria? Well, once again, when we start off, it sounds an awful like the substance use disorder, right? Persistent, recurrent, problematic gambling behavior is indicated by 4 or more of the following in a 12-month period. Needs to gamble with increasing amounts of money in order to achieve the desired excitement. Restlessness or irritable when attempting to cut down or stop gambling. Often preoccupied by gambling. Gambles often when feeling distressed. After losing money gambling, often returns the next day to get even. Lies to conceal the extent of involvement with gambling. Has jeopardized or lost a significant relationship, job, or educational or career opportunity because of gambling. And relies on others to provide money to relieve desperate financial situation caused by gambling. So, I think any of us who have seen somebody who we've called a problematic or a pathological gambler, this is them, right? And the other interesting thing is really, if you substituted a substance, it sounds almost identical. There's even though it's a behavior, which is very fascinating. So, how do you make the diagnosis? You have to rule out a manic episode, impulsivity, is part. The severity, 4 to 5 is mild, 6 to 7 is moderate, 8 to 9 is severe. You specify whether it's episodic or persistent. Episodic means it's sort of like a binge drinker, that there may be episodes of time where they don't engage in the behavior, and then they engage it to such a degree that it meets those criteria. Early remission and sustained remission, same thing as substance abuse. So 3 to 12 months, early remission, sustained remission, over 12. And individuals who present for treatment usually have a moderate to severe form. Rarely do you see anybody with mild. So, that's gambling disorder. So I thought I would go through alcohol use disorder because obviously it is the most common one we run across. And if we go through alcohol use disorder, you've really got the template for all the other substance use disorders. So alcohol use disorder, it encompasses the criteria previously in DSM-5 under abuse and dependence. The recurrent legal problems criterion has been excluded. Craving or a strong desire to use alcohol has been introduced, and it's being diagnosed on a continuum. Now, criterion A section can be considered to fit the overall groups of impaired control, social impairment, risky use, and pharmacological criteria. So all those criteria that I'm going to show you under A fit under these categories. And as I said, all of these criteria, they're a bunch, are the same criteria that are used sort of plus or minus depending on the substance. Okay, so if you think about amphetamines, some of these criteria that I show you would not fit an amphetamine, or they won't fit an inhalant, but others will. So if you just add or subtract depending on the pharmacology of the substance, you're using about the same criteria. Impaired control. The individual may take the substance in larger amounts or over a longer period than was originally intended. The individual may express a persistent desire to cut down or regulate the substance and report multiple unsuccessful efforts to decrease or discontinue it. That person may spend a great deal of time obtaining the substance, using the substance, or recovering from its effect. Now, for alcohol, it does not take a great deal of time or effort to get the substance, right? We all know that. But people can spend a heck of a lot of time using the substance, and they certainly can spend a heck of a lot of time recovering from the use. So, but if we talk about opioids, street opioids, then our proportion here will change, right? But you still can meet the criteria, because it's much harder to find opioids, though I shouldn't say that with the way you can buy prescription drugs on the street, but theoretically it's much harder to obtain, so the proportion may change. Craving is manifested by an intense desire or urge for the drug that may occur at any time, but is more likely when in an environment where the drug previously was obtained or used. Triggers, right? This is a fancy way of saying triggers. That's what that really means. So, side note, this is on treatment, by the way. Does everyone know what a harm reduction model is? Okay, all right. I'm going to put in a plug for harm reduction model. Okay, the reason is, the old school of thought was somebody comes in, they have a substance use abuse problem, and you should basically say you're an alcoholic, and therefore you have to stop drinking, and you can never drink again in your life. Okay, and that person would nod their head, walk out the door, and never come back again, right? Until they're in the street, drunk, run over by a car, right? So, I have seen some really good results with harm reduction models. And I think one should explore that with people. Doesn't mean you change your bottom line recommendation, but I think what you do is you present it as a way of working with that person with the ultimate goal of hopefully getting them to stop. And a lot of times it can work. And I've seen it work very well with a chronic alcoholic who has been through 10 alcohol treatment programs, each time they've relapsed. But you can get them down to 2 drinks a day versus a half a pint a day. You know what? That's better than nothing. And some people you can, and some people you can't. But if you've really got one of those people who they are really going to kill themselves, it is worth a shot. And the problem, I think, is we do not yet know, and we have no way of separating out those people where that model really can work and those people who it can't work. And there probably is some genetic and biological differences, but we have no ability to do that right now. So that's why I think it's worth a shot doing it rather than playing, bad cop all the time with them. If the point is getting people better, a little better is better than no better. So, use may result in failure to fulfill major role obligations at work, school, or home. The individual may continue to use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. Boy, do we see a lot of that, don't we? All the time. Important social, occupational, recreational activities may be given up or reduced because of the substance. Recurrent substance use in situations in which it is physically hazardous. What's the most common thing here? Driving, absolutely. That's where where the legal criteria came in before. What was the most common thing? DUIs or DWIs, depending which state you're in. The individual may continue substance use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. In other words, you're depressed, and the drinking's making it worse, and you keep drinking. So, what is tolerance? Now, once again, remember, tolerance and withdrawal doesn't count if it's a legitimate prescription that they're legitimately using as directed, okay? And that is no different than what AA says, right? Right, BJ?
Right.
Right, DJ? Sorry, DJ. Because a lot of people will get in some meetings where people will say you cannot use anything, absolutely not. And the person has had a fractured spine, okay? And it is impossible for them to not have pain medicine, okay? Does that mean they get to continue to use alcohol however they want? No, okay? But if they're using pain medicine, they can only use it as prescribed in the way it's prescribed for. They only use it for pain. They don't use it to have a party in their head on Saturday night, okay? And there's a big difference, okay? So, tolerance is signaled by requiring markedly increased dose of the substance to achieve intoxication or desired effect to markedly reduce effect when the usual dose is consumed. We all know that they need more and more and more to get the same effect. Withdrawal is a syndrome that occurs when the blood or tissue concentrations of a substance decline in an individual who had maintained prolonged heavy use before. So in other words, they stop, Their blood levels start going down. Alcohol, of course, it's, nausea, queasiness, tremor, headaches, okay, that sort of thing. Cannabis withdrawal. Now, once again, nobody gets cannabis withdrawal, right? Nobody ever gets it. Even though it stays in our bodies, we well know it's deposited in fat and stays in fat for a month, at least a month longer, right? So, if you read these symptoms, how many people have you seen who are chronic users of pot, who suddenly their supply gets cut off, right? And irritability, anger, aggression, nervousness or anxiety, sleep difficulty, decreased appetite or weight loss, restlessness, depressed mood, stomach pain, shakiness, tremors, sweating, fever, and headaches. It can be quite severe. And like I said, the usual reason this happens is because their supplier just got busted and they're in jail.
Or they have to have mandatory UAs.
Or they have to have mandatory
With
UAs.
alcohol.
Yeah, exactly. Or they've got a job interview and they know that they're going to have to be drug tested, right? And they come in and they'll say, "Oh, doc, I'm so nervous and I'm irritable and I'm feeling depressed and I don't know why." And you get the substance abuse history and, "Oh, by the way," and remember the old rule about substance? Whatever they tell you, double it, right? Caffeine withdrawal. Daily use of caffeine, 3 or more of the following symptoms: headaches, marked fatigue, drowsiness, dysphoric or depressed mood, irritability, difficulty concentrating, nausea, vomiting, or muscle pain and stiffness. Anybody who does morning rounds with me knows I always have my coffee cup. So, clinically significant distress or impairment in social, occupational, or other important areas of functioning, not due to a medical condition. So, bottom line about neurocognitive disorders, and I'll give you the quick version, and you can see it when you go read it. There is now a mild and major neurocognitive disorder. Okay, mild neurocognitive disorder was previously called, and it wasn't an official diagnosis, we would just use the term mild cognitive impairment, MCI. Well, that's become a mild neurocognitive disorder. Major neurocognitive disorder we used to call dementia, okay? But now it's called major neurocognitive disorder. And when you go into the DSM, you will see, it'll say mild and major neurocognitive disorder, and then there'll be a list like this of specific mild or major neurocognitive disorders. For example, it'll say major neurocognitive disorder, comma, Alzheimer's disease, comma, and then there are other specifiers. Another one would be major neurocognitive disorder, frontotemporal lobe degeneration, comma. Major neurocognitive disease, prion, or disorder, comma, prion disease. Prion disease is like Jakob Creutzfeldt, some of the slow virus. So what they're doing is they're breaking out that term. You can still use the word dementia. Dementia is still a descriptive clinical term, but it's not a diagnostic term anymore. So you don't code out dementia. But you can still, when you see somebody who is demented, you can still say they are demented, right? But that is not a diagnosis. And so that's sort of the takeaway message, really, for the neurocognitive disorders. Now, I promise I won't go anymore. Under defining that, of course, because it's DSM-5, they've defined, I think it's 6 neurocognitive domains that you evaluate people under, and all sorts of level of functioning, there are examples. But you've got the basic concept, okay? And I think it's clear when you read it. So, all right, thank you all for coming, and next question.